Hi, welcome everyone. So I'll be taking you through this topic today, which is an exciting topic, transient loss of consciousness, syncope versus seizures. I think it's something we see a lot in the emergency departments and in the pre-hospital space where someone has a brief loss of consciousness and you're not quite sure, do they have a syncopal attack? Do they have a seizure? If it was a syncopal attack, is it something serious? Is it something we can just let go? So we'll try and answer some of those questions as we go through this. And feel free to put in any questions you have in the chat or in the Q&A. We'll definitely be able to answer the questions as we go. So you don't have to wait till the end. We'll answer the questions as we go just to so that we are all following the conversation. We'll try to be as less as technical as possible. I love this topic because it's the easiest thing to really distinguish in the emergency department and figure out what needs to be done for which patient. And correctly done can save your patients a lot of time, a lot of money for sure, and a lot of unnecessary testing. More importantly, of course, then you can have a proper plan for your patient moving forward. So I think I'll just kick off with just some basics in terms of trying to define what is what, okay? And there actually are standard definitions of all these conditions. And I'll just take some time to define each of these so people understand when we say someone has had a syncopal episode, what exactly are we meaning? Or they've had a pre-syncope or near syncope, or what is loss of consciousness? So some of these terms, like, as we use these terms interchangeably in our discussion today, then you're clear what we're really talking about for the individual cases. So when you look at what exactly is a syncope, syncope is a symptom that presents with an abrupt, transient, complete loss of consciousness associated with an inability to maintain postural tone. I want to really emphasize on that part of inability to maintain postural tone because it's actually what necessarily happens because someone potentially was standing or was seated and then just all of a sudden flops over or falls down. And that is a classic part of in terms of what we define as syncope. But the other thing and more important thing is a rapid and spontaneous recovery. Okay, so a patient who presents an abrupt, transient, and complete loss of tone, loss of consciousness associated with an inability to maintain postural tone with a rapid and spontaneous recovery. I think that's the key things. All right. Of course, there are many reasons why you could be having this, and we're gonna go into a lot of discussions behind this. But in terms of when we say someone has fainted, that's essentially what they mean. It was an abrupt, it was brief, there was a complete loss of consciousness, and the patient lost postural tone, or well, less collapsed, and then rapid and spontaneous recovery. All right. So loss of consciousness, of course, is a cognitive state in which one lacks awareness of oneself, one situation, and ability to respond to stimuli. Okay, so when you're saying patient is a loss of consciousness, means your patient cannot be aroused in any way. Transient loss of consciousness, okay, another term is a self-limited loss of consciousness, okay? So self-limited essentially means patient briefly lost consciousness, then came back. And that has very many reasons and can easily be defined of. So when you think about patient who says they had a brief loss of consciousness, so there are two distinctions. They either fainted or didn't faint, okay? Now the didn't faint is a whole list of things. The didn't faint could be easily seizures, hypoglycemia, metabolic conditions, drug alcohol intoxication. There's so many reasons of to the non-syncope. So again, the key thing is try to identify who had a syncopal episode, who had a non-syncopal episode when they had a transient loss of consciousness. Now, you'll always hear the terms pre-syncope or near syncope. Okay, so these are essentially symptoms that show up before syncope. So someone explains that they had a couple of feelings that they may not necessarily have fainted, but they have had these symptoms, and they include extreme lightheadedness, visual sensations such as tunnel vision, graying out, and then varying other degrees of altered consciousness. So they're not really losing consciousness, but they're a bit of confusion. But of course, this then could easily lead to syncope, but could also stop before syncope. So you could have patients have what we call a pre-syncopal episode, and they'll come and say, I was sitting, then all of a sudden I got dizzy, I got confused a bit. So they never really lost consciousness, but they more or less sounded like they're having a pre-syncopal episode, and in which case, then again, needs to be investigated accordingly. The one thing we're gonna cover again is the syncope where we have no idea. We have really no idea why this person fainted. Okay. And this is the diagnosis of exclusion, where it's syncope for which you actually can't figure out what actually happened, and you've evaluated the patient and taken a thorough history, physical exam, done an ECG. Maybe one key thing, you cannot talk about syncope if you have not done an ECG. I think that's something that's going to come in our discussion today. If you're talking about fainting or syncope or near syncope or anything that has to do with this syncopal discussion, an ECG must exist. Okay, and we'll discuss the utility of the ECG. So an ECG is a key tool in the evaluation of patients who have syncope. All right, and now let's look at the other part of it. What's a seizure? Now, this one has a bit more complication. So, a seizure is defined as an abrupt disruption of brain function secondary to abnormal neural firing, and it's characterized by a change in sensory perception or motor activity. So, I think the key thing we always think of seizures as, oh, the person has gone all over the place and they're having what you call general tonic convulsions. But clinical manifestation of a seizure is superbly vast. Okay, you can have what is called focal or generalized muscle activity, sensory or autonomic dysfunction, or mental status changes. You could actually have a patient who is just confused, and that could easily be a seizure activity. Okay, so seizures is not always translated to general tonic-clonic seizures, okay, which is what we always see where patients go all the way. You could have focal seizures where the patient has, again, just one hand seizing, that's probably a focal seizure, or you can have a variation in their sensation. So it's not always the GTC, which is the most common one where we see, but again, not necessarily two in that. All right. So that's the definitions, and I hope you're all clear on the different definitions. So for the discussion today, we're really going to focus about how to tell someone who has a transient loss of consciousness. Okay, so we say it's a self-limited loss of consciousness, and here we're dividing it to syncope and non-syncope. Now, for the non-syncopal episodes, how are we defining if a patient had a syncopal episode or just had a seizure? Okay, so that's really what you're going to be looking at today. All right. Just a bit of this. So this is causes of syncope, okay? And as you can see, good chunk, and I think that's something where you need to extra 34% majority of your seizures, okay, will be unknown. Okay. You will have no idea why your patient fainted. Okay. And that's okay. As long as you've done a clear evaluation of your patient, that's fine. So if you don't necessarily have to dig around and do all the tests in the world to figure out why your patient fainted. 34%. So one out of every three patients you see, you will not be able to say why they fainted. Now, for the others, then you will could potentially, from your history and clinical examination, largely from those two, not from your testing, okay? History and clinical examination, you will be able to try and identify what potentially caused the seizure. All right. So you could have patients, for example, who their medication is giving them seizures. And as you can see there, taking medications that associated with the long QT interval or orthostasis. So your antihypertensive medications will give you orthostasis. The long QT is an ECG feature which we'll discuss today. So as I keep saying, syncope, ECG are synonymous. Those two have to exist together. Orthostatic hypotension, again, for those patients who have been standing for a long time, normally seen in military parades or any parades where someone has been standing for a long time, then they just have a syncopal episode, then they wake up. Okay, 8% of the cases. Now, of interest, and that's why again we say the ECG becomes key in our diagnosis, is 18% are a cardiac cause. Okay, 18% of patients who have a syncopal episode potentially has something to do with their heart. Okay, so you could either listen to their heart and hear some murmurs. Okay, or you could have patients who have ECG changes, which we're going to discuss. Or you could have patients who then have issues with their blood flow, especially in the subclavian artery, or differences in BP both arms. So a vascular cause, patients who, for example, has bleeding somewhere or dissection, the many reasons why, again, a patient could have a syncopal episode. So, and again, this is on history and clinical examination, not lab works, not really, yes. And ECG, of course. Then you have the neurocardiogenic. So, patients who have vasovagal attacks. So, these are the patients who, for example, they come across a lion and all of a sudden they're scared and then they faint. Okay, that's a neurocardiogenic. Or patients who I'm sure you may have if you're in clinical practice, you're going to put an IV line for them, and then because of the needle or they're scared of needles, they faint. Okay, that's a vasovagal. Or patients just get shocked or sound or smell, then they just lose a vasovagal attack. Similarly, prolonged standing will give you a vasovagal attack. And then situational, again, you've seen this where someone, for example, was peeing, and because of straining from pee, the collapse, it has happened, or coughing or swallowing or going to the toilet when they're constipated and they're doing the nice number two, and all of a sudden they faint. Okay. So, and the situational ones become very important in trying to understand what were you doing before you had your transient loss of consciousness. Were you singing in a church, meaning you were standing, or were you in the toilet trying to pee, then you collapsed? I mean, so that gives you an understanding that potentially what may have happened. And that's where a proper history of the events surrounding the transient loss of consciousness event become important. And then, of course, carotid sinus issues where you have when you turn your head, you collapse, yeah, you're going to syncope, you get dizzy. Again, some of this may also happen. For example, one is a patient who was shaving in the morning and they're shaving their beard down here. The next thing they've collapsed. Okay, again, you quickly understand potentially something to do with the carotid sinus. And again, may need to be investigated. And then, of course, there's a small percentage who their syncopal episode is related to a seizure. Okay. So the actual 10% of patients who have a syncopal episode may actually have had a seizure. Okay. And we're going to discuss now for this patient. So this is transient loss of consciousness. They've come in and there's a small chunk of them potentially it's a seizure. How do we identify a syncopal episode from a seizure? All right. Now, as I mentioned, seizures are insane in numbers. Okay, so you could have it's either focal or generalized or unknown cause or a known seizure type. There are different epilepsy types. There's focal, generalized, combined generalized, and focal. And then you can see the causes could be the structural issues in the brain, genetic people who have just predisposed because of their family genetics, patients who have infections, meningitis, brain infections give seizures, metabolic derangements, hypocalcemia, that potentially hyponatremia will give you seizures. Immune issues, autoimmune diseases, and again, sometimes patients have seizures and we don't know why. Okay, and that's just how life is. Okay, and so it's again part of your history is trying to identify any of these, any associated symptoms, any comorbidities that may have led to them having a seizure. So this is again why this topic is key and why we chose to do this topic is again. So this could be a nice doggy where we want to go play with the doggy, or it could be the doggy that kind of bites you and kills you and gives you rabies and many things. And that is essentially when you think about seizures versus syncope, that's the kind of situation you're dealing with. You have a patient in front of you where if it's a simple seizure, nothing to worry about. They'll be fine. It's a fast one. Don't really have to do much about it. If it's a simple syncope, that's fine. Nothing to worry about. You can probably send them home. But on the flip side, the seizure could be tumor, could be metabolic impairments, could be genetic. So there, and on the flip side of the syncope is someone who's having potentially a heart attack, someone who's having bleeding, for example, hypovolemia, someone who's having again a seizure. So these patients could easily be just simple, nice patients who are having a seizure or had a syncopal episode, and they're fine and they're good. We'll send them home. Or these are the patients who then are very complicated because now they have multiple problems that you need to deal with. And when they present, they will look at like this dog. Okay, so potentially it's a good dog. I see some teeth. I don't know. So next time you have a patient who has transient loss of consciousness and you're thinking, is this a seizure or a syncope? Just remember this dog. It could be a nice friendly dog, which is simple case of this, or it could be a really bad dog. So the key thing is how do we make sure that this is not a bad dog? Okay. And there's multiple studies that have been done to looking at potential how to easily differentiate syncope versus seizures. And as you can see, this is one of the studies that looked at factors that most strongly predictive of seizures. Okay, so what of this could easily be a seizures? Yes, and you can see if your patient bit their tongue, high likely it's a seizure. Okay, and this is your likelihood ratio, very high likelihood ratio. So we're looking at column 3 here. If there was head turning is where patients maybe lost much of the condition and then start turning their heads or turn their heads on one side. That's most likely a seizure. Okay, they may have just turned it and stiffened on one side. That's a seizure. A patient who has a syncope just falls and becomes very floppy. But if there's active head turning, then that's most likely a seizure. Unusual position posturing, sorry. So patient collapse. Ideally, if it's a single episode, you just and you fall the way you are. But in seizures, the patient potentially was holding an abnormal or unusual posture, okay, of their body. Then that makes it so. And a lot of this is from your history and physical examination. Did they pee themselves? Okay, did they poo or pee themselves? Mostly it's pee. So if they wet themselves, not bedwetting, like in primary school or small boy, but if they passed urine on themselves or passes themselves, they are most likely having a seizure. Okay, so this I want to focus on these top four things because those are the key things we ask any patient who's coming a seizure. Number one, can I see your tongue? Sometimes they bit their tongue and they don't know they bit their tongue. So, can I see their tongue? Can I see your tongue? If there's any bite anywhere, they had a seizure, regardless of what story you're being told. If there was history of again head turning, abnormal posturing, then again, this is from the history, then most likely it was a seizure. If they've come, they had a loss of consciousness, transient loss of consciousness, and they peed themselves, it was a seizure. There's no discussion there. Okay. They peed themselves, it was a seizure. And again, then we need to be managed appropriately. There are so many others. You can see there's a whole list of things, limb jacking, noted by others, prodromal hallucinations, loss of consciousness associated with stress. These are nice to know, but the key ones I'd say are these number 1 to 4 here. They have a cut on the tongue. There was a head turning when they collapsed. There was unusual posturing. So they did not maintain a normal lying down position. They had their arms and knees or legs bent and held in a certain position. If they peed themselves or pooped themselves, they had a seizure. Okay. Now, the other part of it is now factors that most likely say it was not a seizure. Okay, these are also important to say. Patients who, again, if this is some of the things that they have, then it wasn't a seizure. It may actually have been a syncopal episode. Okay. So, and you can see here the likelihood ratios are not as fantastic as the ones we were saying earlier. As you can see, the numbers are quite small. And so it just potentially means no seizure. So, they had presyncopal spells. Remember, we talked about presyncope. And for those who don't remember, presyncopal spells. Okay. So things like visual sensations, tunnel vision, graying out, feeling out confused without complete loss of consciousness. So these are presyncopal. So if they had any of those presyncopal spells before loss of consciousness, it's most likely a syncopal episode. If they say they had a high blood pressure, most likely syncopal episode. Hot and warm environments, if they were about to get a needle prick and then collapse, that's probably seizure. Sorry, syncopal episode. If they had dizziness before they collapsed, most likely syncope. And I say presyncope the exercise. There's a whole bunch of these, but these ones are less specific and less sensitive, I'd say. As you can see, the specific sensitivity is not as great. And that's why not necessarily looking for this. So when a patient comes in, you're not necessarily trying to figure out any of this. You're trying to figure out these three, these four. Did they have a tongue cut on their tongue? Was there abnormal, was there head turning when they collapsed? Was there unusual posturing? Was there bedwetting? We're looking for anything that is highly suggestive of a seizure. Okay, not necessarily looking for what could suggest a syncope. All right. Remember, of the two, the potentially one that needs to be dealt with right now is a seizure. So we're really trying to find the seizure and just say probably it was a seizure. Syncope could be very many other reasons. Okay. Now, in terms of strongest predictors of syncope, okay, you can see these ones are very nice. This is from our study of a lot of international patients. So patients who have palpitations most likely to the syncopal, exertional syncope, they were running a marathon and then collapse. Probably it's exertional syncope. Patients with non-heart disease, patients who have any bleeding at the moment, and that's why it's important to again look for any occult bleeding. Patients who again were sleeping and then just lost consciousness. And then lack of a prodrome again is highly suggestive then of potentially having a syncopal episode. Your prodrome is the pre-syncopal discussions we're having. In one of the studies, actually, they looked at what kind of questions should you be asking, okay, to determine whether loss of consciousness is due to seizures and a syncope. I will share the reference for this in a paper at the end of the presentation. And so a patient, if you look at the bottom part of here, is the patient has seizures if the point score is one or more. Okay, so if you have one or more of this, then it's most likely having a seizure. Okay. If the point score is less than one, okay, then of course, then it's most likely a syncopal episode. And and so at times, so the questions you ask is at times do you wake with a cut tongue after your spells? Remember, as I said, having a cut on the tongue, we're having a seizure. That one gives you 2 points straight up, no discussion. All right. At times do you have a sense of deja vu, jamais vu, before your spells, or just so it's essentially of just like ultra level of consciousness, then you get 1 point. Are there times of emotional stress associated with losing consciousness? You get 1 point. Has anyone ever noted your head turning? See again, head turning becomes a key predictor here. Head turning during a spell, that gives you 1 point. Has anyone ever noted that you're unresponsive, unusual posturing, limb jacking, okay, and have no memory of your spells afterwards, okay? Then you get 1 point. All right. Has anyone ever noted that you are confused after a spell? You get 1 point. So all this that has a positive 1 point essentially are highly high predictors of you having had a seizure versus a syncope. All right. Now, these are the last 3 points are essentially is saying, yeah, this is probably a syncope. Have you ever had a lightheaded spells? If you answer yes to that, you probably have a syncope. That's a 2 marks get out removed. Attempt do sweat before your spells. Again, that's more syncopal. You get 2 points removed from that. Is prolonged sitting or standing associated with your spells. Again, your orthostatic syncope. Again, 2 points removed from that. So the first couple of points essentially high to rule in more or less a seizure episode, and the last 3 points are more or less related to syncope. Let me just see if there are questions that I okay, this is a question, administrative questions. All right, good. All right, so quickly just looking at again syncopal episode, because now even in so if you're having a seizure, that's fine, and we'll look at an algorithm for that because seizures, we're good. It's a very straightforward plan in terms of their management, okay, and then we'll discuss that in part of our algorithms. Now for the syncope, then now we need to figure out well, you fainted. Okay, so fine. Are you a good fainting? Remember the good dog? Are you a good faint or are you a bad faint? Okay, or bad syncope? And so there are multiple risk factors, and I'll quickly just look at some of this. So if the patient had associated prodrome, after sudden and unexpected sight, sound, smell, pain, prolonged standing or crowded in hot places, as they were eating or pooping after or after eating, If they were coughing, pooping, or peeing, and then if it was with head rotation or pressure on the couch, and then see, as I said, shaving, tight collars will give you syncopal episode, okay? And standing from supine to sitting position or sitting position then gives you syncope. So all those are what we call low risk syncopal events. They're really not much. Or you are standing, then you stood and collapsed. That's fine. There's nothing much to worry about that. Or you are peeing and you fainted. Yeah, not necessarily a big problem there. Now, there are a few high risk things that you need to look out for. And again, still, history and clinical examination. That's why this to become a very important part of it. So if the patient has or had any chest discomfort, breathlessness, abdominal pain, or headache, then that's a huge risk factor to factor in. So patients who had syncope during exertion or were supine, so a lying spine and then fainted, something to worry about. Remember, syncope by definition is loss of postural tone. So if you're lying flat and then you fainted, that's a bit off. That doesn't sound like syncope. The sudden onset of palpitations followed by immediate syncope, again, it's a high risk factor. Um, again, as you can see, for the minor high risk factors, this is where you have abnormal ECG or you have abnormally known to have heart disease, no warning symptoms or short prodrome, family history of sudden cardiac death at a young age, syncope in the sitting position, again, is something to really worry about. Okay. So remember, you have to have a loss of postural tone for it to be a syncopal event. All right. The other part, so when you look at things like past medical history, the things that are low risk is long history of recurrent syncope with low risk features the same. So they've had several fainting episodes. Potentially, there's nothing to worry about that. Patient is known not to have any heart disease. That's fine. Patients who have structural or coronary artery disease, patients with heart failure, previous MIs, that's a major risk factor in case they faint. Okay. And of course, when you look at the physical exam, if the exam is normal, you can't find anything in the clinical exam, then most likely it was just a low risk for the syncopal episode. But high risk features when your clinical exam, of course, if they fainted and their systolic blood pressure in the ED is less than 90, need to worry about. Okay. If there are any suggestions of GI bleeding, and this could be melena stools or on rectal examination, you find fresh blood, again, that's something to be worried about. Okay. Of course, abnormal heart rates, bradycardias or severe tachycardias, okay, in an awake state and absence of physical training is something to worry about. And of course, if you listen to the heart and hear a murmur, yes, that needs to be investigated. So that's no longer just a simple, nice syncopal episode. All right. ECG, as I mentioned, is a key clinical feature that needs to be key investigation that needs to be done. And there are so many things that we're looking at on the ECG. So if the ECG is not, if it's normal, fine. Patient is fine. Okay. Nothing to worry about. So normal means you've looked at your QRS complexes, your intervals, PR interval, QRS interval, QT interval, and you looked at this, you look at the heart rate, and everything is normal. It's a normal ECG, nothing to worry about. But things now you have to worry about is, of course, you do an ECG and you're seeing a second or third degree heart block, you're seeing features suggestive of ischemia, you're seeing slow heart rates or persistent bradycardia, you're seeing now anything. To be honest, if your ECG is not normal, you should stop and start evaluating that ECG on a step-by-step basis. Because if your ECG is not normal, then there's a high chance that they have a cardiac cause of their syncopal episode, which then warrants a detailed evaluation, a detailed assessment of your patient. And these things, and there are multiple. There's a nice here, what we call BWAT QT pie. This is American kind of stuff. So I know what QT pie is. But anyway, so B is looking at for your Brugada kind of pattern where you have your deep S waves with a cove shaped ST segment, more than 2 millimeters, essentially in V1 to V3, and a negative T wave. Okay. You have ECG features of electrolyte imbalances, so bradycardia with pitch T waves and wide QRS and low P waves suggestive of hyperkalemia. You have ST depression, T wave inversions, U waves, long P waves in your hypokalemia. You have your short QT and Osborne waves. Osborne waves, as you can see down here. You'll see this kind of a notch in your ECG, in your hypercalcemia, hypothermia, patients on some medications, and subarachnoid hemorrhage. Okay, again, hypermagnesemia is associated with hyperkalemia. You'll see heavy blocks. A long QT again. So QT is the one thing that you have to look for. Does your patient have a long QT? Okay, and when you look assessing the QT, essentially what you're looking for is does the T wave finish before the halfway point of 2 hour intervals, RR intervals? And that essentially tells you a patient has a prolonged QT interval. Okay. So the others are all fancy. As I said, of course, if you have a patient with syncope and you see an ECG that looks like has this, what you call an epsilon wave, doesn't matter what you know, doesn't matter you don't know what that is, it's not a normal ECG. So I wouldn't necessarily say we focus on trying to figure out what an epsilon wave is, or an Osborne J wave is, or what a delta waves is, or features of hypertrophic obstructive cardiomyopathy are. If your ACG is not normal, please, my friend, and your patient has a syncopal episode, then your patient needs additional evaluation to make sure that they are not having a cardiac cause of syncope. So essentially, I know this talks about three different patients or categorization, but as I said, you're either having low risk features, in which case, go home, you'll be fine, nothing to do about it. Or you're having any high risk features or any, and then these patients definitely need to be admitted, evaluated to make sure they're not having a potentially risky cause of their syncope. All right. So just before we go into the algorithms, maybe I just actually let's go into the algorithms and look at what each of the algorithms. So these algorithms are available in the casualty app for those who yes. So you can download the algorithm on the Casualty app. They will then be able to, you'll be able to then access this if you go to our website / casualty, or you are Apple Store, Play Store, you'll be able to get these algorithms. And so if you're gonna look at syncope, so just start with a syncopal assessment. Normally I know how to quickly find them. It's easy on the app. Yes, that's why. All right, here's seizures and there's syncope. All right. So if we look at our protocols in terms of syncope, okay, we start off with the definition. So syncope is a syndrome of complex, actually, brief loss of consciousness, inability to maintain postural tone spontaneously and completely resolves without medical intervention. That's a syncopal episode. Okay. Near syncope, patient as a patient almost losing consciousness and is approached the same way as syncope. So even patients who have a near syncope, you approach them in the same way. So the first thing, of course, again, was it a seizure? Because if it was a seizure, we are the wrong algorithm. We need to go to the right algorithm. And so things to consider was their tongue biting, head turning during loss of consciousness, no recollection of abnormal behavior, prolonged limb jerking lasting minutes, incontinence post-event, incontinence, so they pee themselves, poop themselves, or post-event confusion and a prodromal aura. If they have any of this, they go straight to the seizure algorithm. So if not, of course, we quickly check the RBS. Okay, they may just have been hypoglycemic, and that could easily be the cause. So an endocrinological cause or a metabolic cause of their syncope. Next thing we need to do an ECG. Okay, and again, we're looking for evidence of ischemia, infarction, dysrhythmias, AV blocks, Brugada syndromes, prolonged QT, and abnormal ECG. Okay, if the ECG is not within normal, that may be the cause of the syncopal episode. All right, factor in again, a lot of this will come into the in your history and clinical exam. Things like subarachnoid hemorrhage, seizures. Okay, so orthostatic causes, so ectopic pregnancy, GI bleeding, as I mentioned. Again, are they on some medication who that is causing orthostatic hypotension, especially patients on antihypertensive medications? Cardiovascular causes, as I said, are they having a heart attack? So it's rare, less than 2%, or PE, again, rare, less than 1%. But still think about it. But again, doesn't mean every patient has to go for imaging or blood. This is just from your history and clinical exam. And if your history and clinical exam doesn't really um, pick up any of this, then you go. So we have what we call the San Francisco Syncope rule. Now, again, if you have the casualty app, you've probably seen this. It's yes, it's we have MD Calc that you can link up on the from the app. And MD card, as you can see, there are multiple syncope rules. Okay, so these are tools essentially. So let's look at this one. So the San Francisco syncope rule, which is one we like, essentially predicts the risk of a serious outcome 7 days in the patient presenting with syncope or near syncope. So essentially, the tool was evaluated and validated so that to look at if a patient if a patient meets any of these criteria, a patient with syncope who now find they're in your emergency department and they have no new or persistently neurological deficits. They weren't drinking, drugged or anything. It wasn't a seizure. They just had a transient loss of consciousness. There was no trauma. All right. So is there a history? So chess is a mnemonic. CHESS. Okay, like chess, like the game. So any history of congestive heart failure? No. So a HB, the hematocrit is you divide this by three. So HB less than 10 or hematocrit less than 30%. So again, you need to do a HB. And again, you can assess is there any risk of bleeding. Are they bleeding? Or they've been bleeding. They may have been chronically bleeding. So you need to know what their HB is. ECG, okay. Any abnormal ECGs. And see, abnormal. It's not normal. They get a score, yes. Any shortness of breath symptoms, and then if the systolic blood pressure at triage was less than 90 millimeter mercury. And now, and if you score any yes, okay, as you can see, if we do this, if it's 1 yes, patient is not in there. And see, patient is not in the low risk group for serious outcome, meaning they are at risk. So if you score any one of this, doesn't matter, okay? If you score any one of this, and the more you score, potentially things get more complicated. But any one of this, any one of this tells you patient is not. And then the good thing about the MD card, you can quickly say click next steps. Okay. And you can see the syncope rule is not 100% incentive, but if there's any concern of just laying condition, the patient should do further workup for the patient. And this is how you look at it, systolic blood pressure 90, shortness of breath, pictures of heart failure. If they have any of this, if the answer to any of this is yes, they have a high risk for serious outcome and require to be admitted. That's how simple it is. So just remember chest, congestive heart failure history, hematocrit less than 30%, ECG abnormal, shortness of breath, systolic blood pressure less than 90. If you have yes on any of this, then you probably have you're probably having what's this thing called? A high risk syncopal episode, the bad dog. Okay, so not the good dog, the bad dog. All right, as I mentioned, as a chess. Okay, and the others. I mean, I know there's another one, the Canadian, but again, each of these looks at different things. So if you look at the Canadian syncope rule, again, you see this one predicts a 30 days serious adverse events in patients presenting with syncope. This one has had very many discussions around it because, as you can see, you're doing troponins, not really one that we use commonly because a lot of these patients don't need that much evaluation or that much workup. So the San Francisco syncope rule is probably the easiest to do in the ED. And again, but one of the key things, as you can see, they've said is the clinical gestalt as a healthcare provider still is 100% so 100% sensitive. So what's your gut feeling? And it says emergency physician or someone who has very good clinical acumen would be able to tell if this was a simple syncopal episode or high risk syncopal episode. Okay. All right. So again, your gut feeling is much better. All right. So the other things to look out for is so now what do we do? Let me just share this now. So that was syncope. All right. So let's look at. So your patient, as I said, does any your patient have any of them? If the answer is yes, time to see a physician. The patient, okay. Negative predictive 97%, sensitivity is 87%. As you can see, it's much less than your clinical gestalt. And patients with negative or had a less than 3% risk for serious outcomes. So it's just saying you probably had a simple syncopal episode because you don't meet any of these criteria. You don't have any of this. In which case, then I can happily send you home. But of course, with the caveat, if things do recur, then you should come back because again, there's that still less than 3% risk of a serious outcome. So for quickly on the seizures is not that complicated. Okay, well, on the algorithm looks a bit more complicated. But if you had a seizure, then that's easy. Patient had a seizure, so we definitely come into the seizure algorithm. Okay. And the key things as you use this algorithm to think about is this a first time seizure or was it a patient known to have seizures of or has had multiple seizures? Because the two are very different in terms of your management. And so, of course, the standard evaluation for the patient, do your basic vital signs, give oxygen if they're hypoxic, check your RBS for all patients. And then if it's a first time seizure, of course, rule out malaria, check your electrolytes, HIV, and if pregnant in any way, do a urinalysis. Or if the female, just do a urinalysis. You never know. Okay. And of course, if they are pregnant, then they are probably having a preeclamptic or eclamptic, sorry, having an eclamptic episode, and that management varies. And then, but if they do not have that, then okay. Patients with exposed seizures related to a previously treated epilepsy or eclamptic patients and likely to have life-threatening international causes. So these patients don't need an MRI. So anyone who is known to have seizures and they have one of the usual seizures, nothing abnormal about it, or they have eclampsia, you don't need to MRI them. Okay. There are some patients then who ideally need an MRI immediately. And if these are patients who have new focal deficits, persistent autonomic, they're not waking up, okay? Fevers, recent trauma, persistent headache, history of cancer, history of anticoagulation use, suspicion of AIDS. So MRI is the best for brain imaging, okay? At any point, unless you're talking trauma or stroke where you're trying to thrombolize a patient, if you're going to order brain imaging, order an MRI. Okay. A lot of patients get CT scans that necessarily don't add any value, and the patient still then needs to get an MRI. So, where possible, get an MRI for your patient. It's the imaging of choice for your brain, except in trauma cases or in patients who you are planning to thrombolize for a stroke or your patient can't lie still for more than an hour, for an hour, okay? So there are only three reasons why you would do a CT brain on any patient. Number one is trauma was involved. Number two, you're planning to thrombolize a patient for stroke. And number three, your patient can't lie still on a machine for 1 hour, because that's how long essentially it takes to get an MRI done. So beyond that, please, if your patient meets this criteria, please save your patient's money and time. Get an MRI where possible. Of course, I know MRIs are not readily available across places, but if possible, go straight for MRI versus doing a CT scan. Um, so for patients who have a first-time seizures, you only worry about if they're more than 40 years of age and it was a partial onset seizure. I mean, it's not really a complete seizure. So this one's worry about because no one should be having seizures above 40. And the seizure or there was a partial onset seizure, then you worry about. But again, eventually one is an MRI, but not necessarily say that you really need to panic. Everyone below 40 is allowed to have one seizure, okay? Anything more than one, you have to worry about, right? For patients with recurrent seizures, again, not every time you have someone, let's say, who has recurrent seizures, don't keep imaging them every time, okay? Unless there's a new seizure pattern or a new seizure type, or there's prolonged post-cortical confusion or worsening mental status, right? Again, so patients who you potentially can have happily send home First onset single seizure in a patient under 40 years of age who has completely recovered from the seizure and for whom no clear-cut cause has been identified. So you can't really find out why they had a seizure, okay? And it was the first one, they're less than 40, and the labs up as ordered above are normal. They're not HIV positive, the electrolytes are fine, everything is fine. This guy can probably go home. No really need to worry about that guy, okay? Below 40. Above 40, again. So patients again who are epileptic, who has completely recovered from the seizure and from whom a clear cause was identified. Mostly they've not taken their medication or you've given them the medication. Please make sure you give them the medication. And they have normal investigations. Please, you've loaded them with anticonvulsants. If they're not on the therapeutic dosages, then again, you can send them packing without really admitting them. Of course, consult a physician on all other patients who don't meet this criteria. OBGYN, of course, we are pregnant patients. On this other flip side is a patient who's just continuously seizing. And this, again, I'm not necessarily going through this. You can read through the protocols. It's just what to do at what point to ensure the safety of your patient. All right. So, in summary, um, okay. So, am I sharing the same thing? I think yes, I am. All right, so what do you do? Okay, patient has transient loss of consciousness. What do you do for this patient? Okay, that's TLOC is the transient loss of consciousness. So number one, take a detailed history, especially from the witness. That's the most important. I said you want to know how was this? Was there head turning? Was there abnormal jerky movements? Did they pee themselves, pull themselves? And then carry out a complete clinical exam. Look inside their mouth, okay, and in their pants. Okay, sometimes they may have peed themselves and they don't know. Yes. So look inside their mouth to see if they cut their tongue. Look inside their pants to make sure they didn't poop themselves. If you see any of that, they probably had a seizure. All right. If it's uncomplicated faints, again, as I said, most of this can be diagnosed from history and clinical examination. Suggestive features of an uncomplicated faint. This is a good mnemonic, the three P's. Posture, okay, occurrence when prolonged standing or similar previous episodes avoided by lying down. Provoking factors, pain, medical procedure, they got suddenly scared. And then if there are any prodromal symptoms such as sweating, feeling warm, or hot before the transient loss of consciousness. So the three P's: posture, provoking factors, prodromal symptoms. Okay, any of these prodromal symptoms, pre-syncope kind of things. If any of these, they probably had a simple and complicated faint. Okay, and do not need to investigate further or refer to a specialist. ECG though, please ECG for everyone. Uh, what is suggestive of patient who probably had a seizure? Okay, they bit their tongue, head turning to one side during transient loss of consciousness. They have no memory of abnormal behavior that occurred before, during, or after the transient loss of consciousness. Unusual posturing, prolonged limb jerking, brief seizure-like activity often occurs during syncope, during uncomplicated faints. So that's not necessarily why, just because they moved their legs and hands a bit, doesn't mean they had a seizure activity. Confusion after the event or prodromal deja vu or jamais vu, never seen. So it's like loss of a complete blackout um, after the event that again like suggests epilepsy. Of course, if features of epilepsy are present, go through the protocol, gone through that. Key thing is a lot of these patients, again, the next question would be, did they if they had one seizure, they're less than 40. If they've had two seizures, they need to be put on medication. Okay. Anyone who has had two seizures before they got to you must be on medication and adequate follow-up and management accordingly. So patients who again, as I said, specialists, if I will give immediate treatment for clinical urgent problems, arrange for special ECG for anyone with any ECG abnormalities need a proper cardiac evaluation. All right, so those are like some two good papers that you can look at that help you differentiate between a syncope from a seizure. Very good papers to evaluate. All right, good. Happy to take questions. Let me just go to the Q&A. I see a lot of administrative questions. This again will be addressed by Dr. Lee online at the end of this presentation. And then Evans Udoi, is there any relationship between syncope and seizure where one can exist as a prodromal of the other? Um, Not necessarily. So it's not because you're either having there are two clear distinct conditions, and the etiology is and that's why we went again through the definitions. Let me just quickly go through that to answer his question. So syncope is essentially a transient complete loss of consciousness associated with an ability to maintain postural tone, rapid and spontaneous recovery. Okay. And there are many mechanisms which you've gone through. Now, a seizure, okay, abrupt disruption of brain function secondary to abnormal neural firing. Now, syncope has no abnormal neural firing. Okay. Um, it's just mostly, I mean, there are many reasons why you could have a syncope, but the thing that distinguishes the two is pretty much there's abnormal neural firing and there's characterized by changes in neurological changes. So there's a jerky movements, abnormal sensation, and loss of complete, like for example, when they pee themselves, there's loss of autonomic dysfunction. Mental status changes, of course, where again the confusion, the prolonged confusion after the event, okay, then suggests more of an epileptic or seizure activity. So syncope is just pretty much loss of consciousness. Your brain is within normal limits of a normal person. In a seizure activity, your brain is misfiring, and that again is something that then needs to be evaluated. The next question is atonic seizures is still part of this classification of or was this scrapped with a new classification of generalized focal? All right, so that again is you could have, yes. So these are the different epilepsy types. There's not there's the unknown seizure types is focal or generalized, and the epilepsy types is focal, generalized, combined generalized and focal seizures, and then unknown. Yeah, I think this is the new classification, so I don't think the atonic one still exists. But please consult with a neurologist for that one. I'm not that conversant with the current terminologies around seizures. Um, any relationship between syncope and hysteria? Yes, your hysteria falls under this. As you can see, low risk syncopal episodes after sudden, unexpected, unpleasant sight, sound, smell, pain, okay, where people then now get hysterical, easily could lead to a syncopal episode, okay. What else was that? Again, yes, I think it's unpleasant sound, sights, pain, or just emotion. A lot of emotion could easily lead to a syncopal episode. Yes. Is alcohol intake a predisposing factor to any of the two? Alcohol intake in general is not a good thing, but yes, you could. It's not necessarily a predisposing factor. Alcohol intake could give you. I mean, you could be too drunk and lose consciousness. So you'll have that won't be a transient loss of consciousness. You'll probably have a blackout. Okay, it's not necessarily a seizure. Again, too much alcohol, or for example, alcohol withdrawal symptoms can predispose you to having seizures. So it's not necessarily 100% correlation. I'm not saying you go take your alcohol, but you will faint, but not because you took alcohol, but many other factors could come in. Role on EEG in unclear seizures. Yes, all seizures must be referred to a neurologist. Okay. Anyone with seizures will need to be seen by a neurologist. Okay. Our assessment, the emergency care setup is not the end for them. They all must be referred to a neurologist who then will figure out the different seizure types, get an EEG done, and manage and follow up these patients. Seizures like hypertension, diabetes, and any other chronic disease is a chronic disease and need clear follow-up and clear treatment paths guided by the specialists. Okay. Silent seizures where there are no physical manifestations, there will be always physical manifestations. Okay. And I think that's the discussion is coming up because you see, for example, you have a patient with tachycardia. Okay. From the questions, I think we probably need to do a whole session on seizures. But again, you will have focal seizures could be again, you'll just see eye twitching, for example. So the seizure activity may not be directly obvious. And sometimes, especially when you have patients who, let's say, they're intubated, ventilated, and paralyzed, you'll just see things like tachycardia on the ECG, and then you know. So, as far as I know, these are the yeah. So what I'm presenting is the different classifications of seizures. So the silent seizures and the rest have more or less been moved out and now just classified as general focal or combined general focal or unknown seizure activity. But again, all this patient there needs to be get an EEG done. And I know the concerns here is patient potential, as you said, may not have demonstrated the jerky tonic-clonic movement. Remember, jerky tonic-clonic movements are not necessarily diagnostic of a seizure, okay? You could have abnormal limb movements with a syncopal episode, but the things you're looking out for is, was there prolonged confusion post the event? Was the patient bit their tongue, abnormal head turning, abnormal posturing? Did they pre-poop themselves? So it's not just one thing. Okay, so it's not necessarily just saying, oh, they lost their consciousness. Oh, now I'm thinking it's a seizure or an abnormal seizure or a seizure we've forgotten. I don't know whatever terminology they're using. There are other factors that will easily tell your patient's having seizures, even in the absence of your generalized tonic-clonic seizures activity. Sorry. Answer that. In your opinion, the use of spirit to awaken hysterical patients. Please, guys, let's not punish our patients. Okay. Yes, if they're hysterical, you can't necessarily, you don't need to use spirit to wake them up. You can assess them and then just let them wake up. Let them lie there. At some point, they will get tired of sleeping and will wake up. Okay, let's try not to punish them in the process of trying to confirm they're being hysterical. Sometimes just let them be. And when no one is watching, they kind of miraculously just wake up and they're fine. Well, we've done multiple presentations around ECGs. So if you go to our website, emergencymedicine.org/ECG, you will find a lot of resources for ECGs, ECG learning videos. So we've done this before, but we will definitely pick it up as a topic in the near future. Another question, is there an algorithm applicable pediatric population or is it only for adults? Mainly, we're looking at it from an adult perspective. But essentially, again, syncope is syncope. Even when a child fits, the syncopal presentations are more or less the same. Of course, this is a child who is, of course, walking, talking, and you can assess their clinical features appropriately. Syncope in non-verbal children is really rare and probably needs to be investigated more keenly versus any child who's in the verbal age. All right. Not sure if you covered this, but what would you have say about psychogenic non-epileptic? So a lot of these definitions have moved. So the seizure definitions are very clear. The seizure categorizations, let me put it that way, not definitions. Seizure categorizations have removed a lot of this psychogenic non-epileptic. There's nothing like that now. Okay. He either had a seizure or not a seizure, and then of course in which case then they're managed accordingly. So I'd say that focal and generalized or unknown. Yes. So these other terminologies have all really been scrapped off. Um, and then what about pre-interns? Okay. Again, this I think is going back to the discussion on actually online. So on the platform, there's a category called others that you can register as. And I think clearly because there are many new categories coming in, and I don't think that online can potentially cover all or may know all of them. So there is a category called others, and which you can register under. And I know there's a requirement for you to put your board or registration number. For those who don't have a board or registration number, you can just put your practice license number if you're a paramedic or an EMT, or you can then put your student number, like it's put a number. Okay. That is more important if you're looking for CPD points. All right. We are working, so the algorithms, a lot of them can be applied to the pediatric population, but we're working to get pediatric algorithms incorporated into the casualty app. So that is definitely work in progress. Narcolepsy, cataplexy, catalepsy, these are not seizure activities. These are independent conditions, and they're actually not syncope or seizures. These are actually well-defined neurological conditions out of the scope of the discussion for this presentation. All right, good. I think I've been able to capture most of the questions. Unless there are any further last questions. All right, thank you everyone for joining us today. And thank you, Dr. Online and Lily, for always being a good host for us. And get the Casualty app and enjoy emergency care.